When discussing ethics in healthcare, we often refer to the four basic principles when evaluating the merits and difficulties of medical procedures. Ideally, for a medical procedure to be considered ethical, it must respect all four of these principles, namely autonomy, justice, beneficence, and non-maleficence. Autonomy requires that the patients have autonomy of thought, intention, and action when making decisions about their health. The decision-making process must be free of coercion, and in order for a patient to make a fully informed decision, they must understand all the risks and benefits of the procedure. Beneficence demands that the procedure be provided with the intent of doing good for the patient involved, and that we consider the individual circumstances for all the patients and strive for net benefit. Non-maleficence requires that a procedure does not harm the patient undergoing treatment, neither should it harm others in society. In some cases, it is difficult for doctors to successfully apply the do no harm principle. And finally, justice is the idea that the burdens and the benefits of treatments must be distributed equally among all groups in society. It requires that procedures uphold the spirit of existing laws and are thus fair to all players involved. The healthcare provider must consider four main areas when evaluating justice, namely the fair distribution of scarce resources, competing needs, the rights and obligations of all parties, and the potential conflicts with established legislation. I'm now going to go through each of the four principles individually. With autonomy, it would be difficult to argue that Montgomery does not respect the right of the patient to their autonomy. Framing it purely from a dental perspective, they have the right to information about the treatment proposed. Dentists rarely encounter situations where the information they have to relay is psychologically upsetting or relating to matters of life and death. It can be difficult for dentists to accept, because of the various options available, that the option of no treatment is invariably always there. Should a patient choose the no treatment option, it can definitively lead to further issues in the future. We can respect the patient's autonomy and accept that they have the right to make their own decisions based on the information they want to receive to make that judgment. But how do we live with that as ethical practitioners, knowing the damage the patients may well be doing to themselves? There are many people critical of medical paternalism, but there are those who defend the practice due to the complexity and difficulty involved in understanding the medical procedures proposed. How can we as clinicians really relay the risks involved in a procedure when the science behind it is so complex and at the same time so poor? Even something as seemingly simple as water fluoridation has no real hard data. Cochrane Review 2015. We can never be sure how effective our treatment will be, and there is always the risk that the information we give the patient is wrong for that individual. That being said, well-established treatments do tend to work as expected in the majority of cases. There are thus challenges with Montgomery when it relates to autonomy. What happens with the patient who doesn't want treatment, but refuses to be told the consequences of such? Do we need to obtain consent to give consent? Faced with a patient who stated, "I don't want to know anything," do we respect that decision or plough on regardless with our established consent process? With that small factor being addressed, on the whole, I do feel the Montgomery ruling respects the right to autonomy, and the profession will have to adjust to the new reality. With regard to beneficence, giving patients the consent they need to make decisions about their own health is not necessarily a benevolent act. If it is more likely an example of obligatory beneficence. In the current litigious and regulatory environment, it could be argued by some to be, at least in part, an action of self-preservation by the clinician. The consent process should be a dynamic give and take between patient and clinician, where together they co-diagnose the problem and decide on the way forward for treatment. The whole ethos, however, falls apart when fear and resentment are added into the equation. Fear of being sued and being referred to the GDC, and resentment about the culture dentists now find themselves working in, which does not reflect the spirit of beneficence. If this was the aviation industry, where a culture of learning and growth rather than punishment and retribution exists, Montgomery would be a welcome addition to the law. However, in our adversarial system, it is my opinion that the right things in a lot of cases will be done for the wrong reasons. This is not to say that clinicians do not have an obligation to engender beneficence in their role towards their patients. We all want to help our patients as best we can, and thus avoid doing harm. But what if, by giving the patients the information they crave, the patients make a decision that harms themselves? How can such thus be for their benefit? We inform them there is a selection of treatments to address a problem in the consent process, only for the patient to decline treatment or pick the option we feel is wrong for them. I personally have seen this several times, only for the patient to return with, say, a swollen face and even a systemic infection. Montgomery respects beneficence to a degree, but there will be times where information overload and a patient's own bias may result in the patient doing the wrong thing. In such a case, a dentist's compliance with Montgomery would not be in the patient's benefit. With regards non-maleficence, or as others would say, do no harm, to not obtain consent is, in the English law, an act of battery. So clearly one can imagine that going out of our way to get clear, valid consent is a non-maleficent act. By giving the patient the desired information and by performing treatments competently, we can, in the majority of cases, avoid harm to the patient. There is, however, a perverse incentive in dentistry that is rarely talked about. Dentists profit directly from treating the patient. And although we can try and deny it, there will be some dentists who would like to veer the patient towards one treatment rather than the other. And we're not just talking about money. Dentists prefer doing certain treatments over others, and this bias can cloud the decision-making process in a paternalistic system. Also, in a fixed cost system like the NHS, there is again an incentive towards supervised neglect and to choose simple and quick treatments over expensive and time-consuming activities, such as molar root canal therapy. This is arguably one of the major reasons for the development of the GDC standards on consent, and I feel that the Montgomery ruling may be a powerful tool in combating these less than ethical approaches. The fact is, though, that we should not, in an ideal world, need law and guidance to force practitioners to act ethically. It should be a natural part of the job. I think Martin Kelleher summed it up best in his discussion on the daughter test. From his article, The Problematic Ethics Facing the Profession can best be summarised by the following comment from 2010. Porcelain deficiency disease is an imaginary disease that apparently can only be cured by the removal of sound enamel and dentine and replacing it with porcelain. There is another argument that by giving patients information that we wouldn't normally relay to them, we can in fact scare them into delaying or refusing treatment. With the arguments presented, I do think on balance, Montgomery helps support the ethical concept of non-maleficence for most patients. And finally, justice. When it comes to the concept of consent, Montgomery does help promote equality in how consent is obtained across the population. Even if it could be argued that the compliance at Montgomery by professionals is based on fear, and from a perspective of self-preservation, all patients should be treated equally. The problem with this is that not all patients are being treated equally at present. Many healthcare workers still taking a paternalistic view on consent. And whilst this isn't the fault of Montgomery, it does produce an unwanted side effect: the risk of increased litigation. The concept of justice also concerns the equality of the delivery of care. The majority of healthcare in the UK is provided through state funding, the pot of money thus being finite. And whilst there is definite inequality on the provision of this healthcare due to regional variation, I would argue that Montgomery will actually worsen this provision due to the increased litigation it will cause, as well as the increase in time needed for compliance recording. Even before the case was brought to the High Court, medical professionals were practicing in a climate of fear. As reported by the Daily Telegraph in 2017, 80% of GPs now routinely perform unnecessary tests just to cover their own backs. This adds to the strain on the health service and increases the cost of private health insurance. There will also be an increased strain on healthcare provision due to the amount of extra time that will be needed to obtain consent under the Montgomery provision. More time on patients means less availability in a country where the NHS dental provision can only really cover 50% of the population as it is. This climate of fear, whilst not exclusively down to Montgomery, will only be made worse by the ruling. The risk that more dentists and medics will risk a claim of battery instead of negligence will dishearten an already demoralised healthcare community. Without serious reforms to medical negligence law, Montgomery seriously risks bankrupting an already cash-strapped NHS, as well as pushing private fees up out of the range of the average individual. How much money does the NHS have to set aside to deal with potential litigation now, and how much will it have to set aside in the future?